Surinder is the deputy trial coordinator, and Craig is the trial coordinator working on the trial. Unfortunately, Rob Hinchliffe, who's the UK CI, he's unable to attend last minute because he's got to do some clinical duties. So I'll cover the bit he usually does. I'm not clinical. If there are any specific clinical questions, I will give him a call straight afterwards and then get back to you as soon as possible. But yeah, I hope that's okay. So moving on, it should take around about an hour this session, depending on how many kind of questions we have at the end.
Thank you.
Okay. Brilliant. So just to kind of give you a bit of a summary of kind of what we're going to go over in the session. So I'll introduce you to kind of our UK trial team. I have to do a bit of a refresh for everyone just on GCP principles. Then I'll go over the kind of rationale, aims of the trial, the eligibility criteria, patient screening, enrolment, randomization and follow-up processes. And then Craig, I'll hand over to Craig and he'll talk a bit about the IMP used in the study, safety reporting and completing the CRFs. And then Surinder will talk a little bit about the study website, which kind of hosts our study documents and training materials, and our trial management system where you're required to kind of complete an online delegation log. And then finally, we'll just look at some of the kind of remaining steps involved in setting up your site. So on this slide here, you'll see some of the trial team. So just to note, the LeaderPad is a large international study. So it's being led and been designed by a group of researchers at Population Health Research Institute in Canada. And overall, the kind of study is looking to randomise just over 6,000 adults with peripheral artery disease. In the UK, we have our kind of separate funding. So it's funded by the British Heart Foundation, and the sponsor is the University of Bristol. And the day-to-day management of the trial in the UK has been coordinated out by the Bristol Trial Centre, and that's where myself, Surinder and Craig work. And we're your kind of points of contact during setup, conduct and close down of the study. And in the UK, we're looking to bring on board around kind of 20-25 sites, and we have our own randomisation target of 1,500 participants. So yeah, because you can see our pictures on the kind of top 2 rows there. And then the third row just is detailing some of our kind of UK co-applicants, collaborators who are part of our wider kind of trial management group. So moving on to GCP. So just before we kind of start study specific training, I do have to sort of just remind everyone of the importance of GCP. So obviously GCP is an international ethical and scientific quality standard for the design, conduct, performance, monitoring, auditing and recording and analysis and reporting of trials. And obviously it states that the rights and safety and well-being of trial subjects are the most important considerations and should prevail over the interests of science and society. And that all clinical trial information should be recorded, handled, stored in a way that allows accurate reporting, interpretation and verification. So by attending this SIV today, you're being trained to perform your role in LeaderPad. And it's kind of one of the ways you're ensuring that you're compliant with GCP. Anytime you see that little green key on the slide, it just means that we're noting a key aspect of GCP that is relevant for LeaderPad. So just to kind of give a bit of background to kind of the rationales and aims of the study. So atherosclerosis, obviously a chronic inflammatory disease, and it's one of the major causes of MI, stroke, acute limb ischemia and related mortality. And it has 3 clinical manifestations, and they are coronary artery disease, cerebral vascular disease and peripheral artery disease. And although PAD is the least recognised of those 3, it still affects over 230 million people worldwide. But kind of at the moment, kind of secondary preventions are looking at kind of PAD, lifestyle changes, risk factor modification and anti-thrombotic therapy. But despite those, that population still have a very kind of high risk of acute vascular complications. So clearly there's a need for some additional strategies to reduce that risk in this population. And although atherosclerosis is fundamentally a kind of a lipid-driven inflammatory disease, most of the interventions to date don't actually address that inflammatory mechanism. And that's where colchicine comes in. So it's a low-cost anti-inflammatory drug, at the moment very commonly used to treat gout. And it's effective and safe at reducing vascular events in patients with coronary artery disease, but it hasn't yet been tested in those with PAD. And on this slide, it just shows the results of a meta-analysis of 5 studies looking at colchicine in coronary artery disease. And they showed a pooled relative risk reduction of 25% in MACE for participants randomised to colchicine. But it's thought that those with peripheral artery disease stand to benefit even more from treatment than those with coronary artery disease because they have more extensive atherosclerosis, more pronounced inflammation, and a higher cardiovascular and adverse limb risk. So that's where the objective of LeaderPad comes in. So it's looking to examine the efficacy and safety of colchicine 0.5 milligram daily in reducing the incidence of cardiovascular death, MI, stroke, or severe limb ischemia requiring an intervention, including major vascular amputation in PAD patients. So already mentioned it's part of an international project. So there's a number of countries already open. So obviously we're open in the UK, Australia's open, Canada, Switzerland, Netherlands, Brazil, and Ecuador are currently open, and there's a number of other countries they're looking to open before the summer of this year. In terms of the UK, this slide here just shows the sites we've kind of been engaging with throughout the UK, and at the moment we're open in Leeds, Mid-York, Bradford, Sheffield, Hull, Leicester, Cambridge, Norfolk, Guy, St George, Southampton has already been opened, Sussex has been opened, and we've also got Plymouth open, Bristol, East Kent, and there's a couple of, and Edinburgh as well, and there's a few others on this list that are currently in setup like yourself. Moving on to trial design. So LeaderPad is a randomised double-blind placebo-controlled trial with an active running period where all participants take colchicine. So on the next slide here, you'll see the trial pathway. So potential participants kind of undergo an initial eligibility assessment, and then they're consented into the trial, and they then proceed with an active running period, which involves taking colchicine for around 2 to 3 weeks. And at the end of that running period, they're assessed for tolerance and also adherence. And if they're adherent and tolerant, they're then randomised to 0.5 milligram daily of colchicine or a matching placebo tablet. And then they're then followed up 6 monthly until the end of the trial. In the first year, there's also a couple of additional adherence call checks at 3 and 9 months. In terms of primary outcomes, the primary outcome is the rate of major adverse cardiovascular and limb events, and it's a composite outcome consisting of cardiovascular deaths, MI, stroke, and severe limb ischemia that requires a vascular intervention or major vascular amputation. And there are also a number of secondary outcomes, so looking at those outcomes that make up that composite primary outcome individually. There's also some quality of life outcomes that are assessed via questionnaires that the participant completes at randomisation and then annually after that. And there's also a number of safety outcomes and some other outcomes of interest as well. And these are all detailed in full in the study protocol. Next, moving on to study eligibility criteria. So you should have all seen this in the study protocol. So we're looking at patients that are over 18 years and have symptomatic lower extremity PAD, and they need to fulfill at least one of the following A, B, C, or D that are listed on the screen here. In this trial, we do require that eligibility is signed off by a medically qualified doctor who's been delegated the task. And that's signing off for both starting the active running medication and also signing off to say that they're happy for the participant to be randomised at that point as well. There are also a number of exclusion criteria, so any contraindication to colchicine, long-term requirement for colchicine for another clinical indication, active diarrhea, EGFR less than 30, cirrhosis or chronic liver disease, and any women who are pregnant or breastfeeding or of childbearing potential not protected by highly effective contraception or planning conception during the study. There are also a number of drugs that are excluded if a participant is either on them or got planned long-term use of them, listed under point 7 here. Patients who are deemed unlikely to return for follow-up, patients with a life expectancy of less than a year, a male participant shouldn't father a child during the trial or for at least 6 months following termination of the study drug. We've referenced to contraindications, so patients with blood disorders linked to bone marrow suppression do need to be excluded. Patients with anemia due to other causes, for example, chronic disease or iron deficiency, they are able to take part in the trial. Patients with kind of rare hereditary problems of galactose intolerance or lactose deficiency or glucose galactose malabsorption do need to be excluded from the trial. In terms of co-enrollment, so participants can take part in other clinical trials, includes both interventional and non-interventional, and it does include CTIMPs. Largely this is based on whether the burden is too much for the participant or not, and also whether the other trial protocol permits it. So it is decided on a case-by-case basis. We have a list of about 4 or 5 trials where we have co-enrollment agreements in place, but each time, if you do get, and we do list them on the trial website, the ones where we've already got agreements in place. But if there's any new patients you come across that are in studies that aren't on that list, if you let us know, we'll talk to the UKCI and also the other team that are running that trial and see if co-enrollment is agreed. With patients that have got upcoming revascularization surgery, we ask you not to enroll them into the study until they've had that surgery. That's because revascularization is a study outcome. And participants do need to be advised against drinking grapefruit juice during the trial. So after a kind of participant has undergone that active run-in phase, there's certain criteria that need to be met for them to be randomized. So they must have taken a minimum of 11 tablets and reported 80% drug adherence. And as mentioned, a medically qualified doctor needs to have assessed the participant as tolerating colchicine, and the participant obviously needs to be happy to be randomized. Participants aren't eligible if they've received renal replacement therapy, had a new episode of peripheral neuropathy or neutropenia during the active run-in period. Oh, sorry. And just to note, we're taking a pragmatic approach to GI side effects. It's kind of based on evidence that severe side effects are quite rare. So mild GI side effects are to be expected, and they do usually subside within a few days of the participant starting colchicine. So we do ask sites to make participants aware of this before they start the active run-in period. Next, moving on to patient screening and enrollment, and just to note that we do have study manuals for all kind of different stages. So we've got one for screening and enrollment, randomization, follow-up, and so on. In terms of identifying patients, so they can be identified through referral letters, clinic list, admission records, or identification during ward rounds. There's also an option to look back at patients that are no longer part of hospital services, have been discharged, and writing that out letters to them with a summary of the study, and then asking them to get in contact if they're interested in taking part in the study. Just to note, obviously, all potential participants do need to be provided with the PIL, which a member of the local research team does need to go through with them and answer any questions. And in terms of what sites are doing kind of across the board now, I think it's a bit of a mixed approach. Some are finding it easier to approach patients when they're on the wards. So patients that have come in for surgery, they kind of consider themselves having a near miss, and they might be more easily to kind of engage and talk about the study, and others are finding it easier to approach kind of an outpatient appointment. So there's a bit of a kind of finding the model that works kind of best for your team. In terms of consent, so in LeaderPad, it can be a clinician, it can be a research nurse, just anyone who's improved on the delegation log by the PI. And obviously, informed consent is obtained by revisiting kind of the study information that's provided and making sure the participant understands the study, the risks, and kind of what it involves. And sort of assessing that understanding by getting them to explain what they know about the study and what they understand, and answering any kind of additional questions that they may have. Just to note, in the UK, we don't have permission to upload any consent forms onto the study database because that's hosted by the international team in Canada. But we do ask for you to send copies of the consent forms to us via encrypted email for our own kind of monitoring purposes. And yeah, obviously for all consented patients, you do need to send a letter to the GP informing them that they are in the trial. So on this slide, you'll just see the two kind of stage kind of screening process. So all patients who meet the first two trial eligibility criteria, so they're over 18 years old and have symptomatic low extremity PAD, they need to be screened in full. And we provide you with an Excel screening log, which we ask you to capture all those participants on, because only the consented patients go onto the actual database. Participants are then provided, obviously, with the study information and approach for consent. All consented patients are added to the study database. And you find with consented patients, they may need to undergo a final eligibility check. So they might need a blood test for EGFR if they haven't had a recent one. So it's 3 months for outpatients and 72 hours for inpatients. And they may also need a pregnancy test if they're a woman of childbearing potential. If they're eligible, they're then enrolled into the active running phase where they're prescribed colchicine for a 2 to 3 week period. And then just to note, with regards to kind of screening logs, we do ask that you return those to us on the kind of first week of each month with the identifiable columns removed. And that's just so that we can monitor screening and new recruitment throughout the UK. So on this slide, you'll just see post-consent assessments that might be required. So as I mentioned, if participants haven't had a blood test to confirm that EGFR eligibility criteria, so it's within the last 3 months for outpatients or 72 hours if they're inpatients, you'll need to take a blood test to confirm that criteria. And you may also need a pregnancy test if you have any female participants who are childbearing potential. So on this slide, you'll just see a list of baseline activities that are carried out. So for outpatients, would you recommend that you send out the kind of study information in the post in advance of their next kind of outpatient appointment? And then at their outpatient appointment, you can consent the patient if they've had enough time to consider the study, take samples for creatinine testing if you need to, if there's no recent results, pregnancy test again if you need to. And then once those results are available, they can be contacted to arrange a visit to hospital where they can be given that colchicine prescription for the active run-in period. And if a participant is eligible for the active run-in, kind of the following tasks need to be completed. So you have to go onto the study database and you have to enter data from run-in CRFs onto the study database. And then you have to go into Roam, which we'll cover in a bit more detail later on, which is the online IMP management system. You complete a form in there, which will then give you a kit number to prescribe to the participant. You then need to complete a LeaderPad prescription form. And just to note, I've been speaking to your pharmacy and they're developing their own prescription template, which once finalised will be shared with you. They will then write on to that prescription the kit number that's been allocated by Roam. And then that prescription gets signed off by the study doctor and also the pharmacy team. Just to note that the Roam system, when you go on and you get that kit number, it does fire off an email to everyone who's registered with that system with confirmation of that kit number. And you are able to enter data onto the study database after the medication has been dispensed if there are time constraints for some reason, in which case you can do it on paper first. So we provide PDF copies of the CRFs which can be printed out. And then obviously once they've a prescription has been completed, you can then give the participant the allocated box of the 20 colchicine tablets for the active run-in period, and also a patient card detailing that they're on the study and they're taking colchicine. For cases where patients don't take the minimum number of tablets, for example, because they've lost the medication, there is an option to repeat the run-in process for them, and the exact kind of steps, same steps apply, but there's some additional rerunning CRFs that need to be completed. So you'd enter the rerunning CRFs onto the study database, complete a rerunning form on Roam, that online IMP management system, to get a kit number, complete a prescription with the kit number on, and then that gets signed off by the study doctors and pharmacy team. Next, moving on to randomization. So on this slide, you'll see kind of an outline of activities and data that are kind of collected at the randomization visit. In terms of clinical assessment, that includes kind of vital signs information. So it's ABI, heart rate, height, weight. And there's also free quality of life questionnaire, so EQ5D, which you're probably familiar with. There's a vascular questionnaire and a standard assessment of global everyday activities, and they're completed at randomization and then annually by the participant. So if a participant is eligible for randomization, then the following tasks need to be completed. So again, you go onto the database and you enter the randomization CRFs onto the database, and you complete a randomization form then in Roam, which allocates some kit numbers to you, which you then need to complete on the leader pad prescription, which then gets signed off by the study doctor and the pharmacy team. Again, the Roam system, once you've got those kit numbers, it will fire off an email to everyone on that system with a notification of the kit numbers that are to be dispensed. Again, if there are time constraints, in terms of the data on the database, you can enter that after the medication has been dispensed to the participant, as long as you complete the information on paper first. And with annual kind of follow-up visit, the exact kind of same process happens. So you complete data from the CRFs for the follow-up visit, you go onto the Roam and you complete kind of a follow-up form within Roam to get the kit numbers, put them on the prescription, and again, they get signed off. And we do have a target for sites to randomise 3 participants per month. And then patients, obviously, if they've been randomised, they get given their free boxes of the blinded study product and a patient card detailing they're in the study and they may be taking colchicine. And the same kind of number of boxes are provided at the annual follow-up visits. The only time a different number of boxes are provided are in cases of lost medication. And you can do that by selecting an unscheduled visit within the online IMP management system. Next, moving on to follow-up visits. So on this slide, you'll just see an outline of activities data that are collected at the follow-up visit. So in the first year, there are also 2 follow-up kind of phone calls that I mentioned. For creatinine and EGFR results, there are guidance in the protocol about that. We'll also go through that in a couple of slides' time. For full blood count results, you're looking out for results that indicate bone marrow suppression, aplastic anemia, because they've been shown to be related to colchicine use. And any out of range results at those yearly appointments do need to be reviewed by a study doctor. In terms of final follow-up visits, so they're scheduled within the kind of last 6 months of the UK follow-up period. At the moment, based on our funding, it's probably going to be the latter part of 2028 or the early part of 2029, but we'll be in touch when we get near that time point. On request of the MHRA, at 6 monthly follow-up visits, women of childbearing potential do need to be asked to confirm they're still using highly effective contraception. And if they're not, then you'll need to do a pregnancy test with them. Women of childbearing potential who've stopped using highly effective contraception do need to be discontinued from treatment in the trial. And the site investigator does need to follow up any pregnancy occurring during the study in a female participant or a partner of a male participant to ascertain the outcome. With regards to annual EGFR and full blood count monitoring, where results are not available during the study visit, if there are no other safety concerns or other reasons for discontinuing the study medication, the medication can be dispensed. And then if once available, the results indicate that the participant should be withdrawn from the study treatment, then the site do need to contact the participant to inform them of this. And that process has all been agreed with the MHRA and is written into the protocol. In terms of kind of drug dosing modification, so if a patient does experience any GI intolerance during the trial, the protocol recommends that the study medication is reduced from daily to every other day until 7 days have passed or the patient's side effects have resolved, kind of whichever occurs first. It can then be reintroduced, or study doctors might choose to prolong the dose reduction or temporarily interrupt the medication for a further 7 days. Any kind of reasons for permanently stopping medication obviously do need to be documented in the CRFs. And in terms of other kind of temporary permanent discontinuation processes, so if at any point treatment with open label colchicine is required while they're in the study, obviously the study medication does need to be temporarily discontinued until the open label treatment is no longer required. The same if any temporary therapy with any of the contraindicated drugs is necessary. Again, the study medication should be temporarily discontinued until completion of therapy with that contraindicated drug. If the study drug needs to be discontinued, also if there's acute kidney injury or if EGFR falls below 15. If it falls between 15 and 30, then interruption kind of the study drug is at the discretion of the investigator. If it is continued, then creatinine should be monitored as clinically indicated in accordance with guideline recommendation. And I've already mentioned, obviously, female participants who've stopped using highly effective contraception do need to be withdrawn from the treatment, and any pregnancies do need to be followed up during the trial. Now I'm going to stop sharing and let Craig share for the next section. So I'll stop sharing there. I don't know if there was any questions up until this point, just while Craig gets the slides up. No?
Can I, sorry,
Yeah.
Can I quickly ask if a patient was in kind of the run-in period or already kind of randomized and they then went on to have a revascularization surgery, does that automatically exclude them?
No, not at all. So that would be a study outcome, and you document it on the form. And even there have been some cases where people haven't known and they've had a revascularization even between the run-in and the randomization form. And that's fine, just document it on the database. So it's not an official exclusion criteria. It's just that obviously you wouldn't expect colchicine to have had a benefit before. If it's already been planned, that wouldn't have been, it wouldn't have been it could affect kind of the study outcomes and the analysis of the results. So that's why we ask you to enroll them once they've had that kind of planned procedure, if you know about it. But if you don't know about it, and sometimes things are booked in last minute, that's fine. Just document it all in the CRFs in the database.
Thank you.
I think you're still showing in.
Yep.
Not in the slide mode. Craig, just let you know.
No other questions? Okay. All right. Does that come up? There we go. Okay, so I'd like to talk about the IMP now. So the active run-in and blinded product being manufactured by Tia Pharma, who have been contracted by the international sponsor. Tia Pharma will be doing 2 manufacturing campaigns. They've obviously completed the first one. The second one will be done later 2026 or into 2027. In the UK, Aeromol being contracted by us to store and distribute the IMP to sites. There will be up to 6 dispatches to sites during the trial. The initial order and subsequent orders will be placed by us, the UK trial management team that is. The initial order will contain 6 months worth of study medication, and that's based on the 3 randomisations a month. This equates to roughly 60 blinded product boxes and 24 active run-in product boxes. As well as acknowledging stock on the Roam system, once delivery from Aramol has been received, you will need to download the temperature data. Aramol will provide temperature loggers and instructions on how to do this for each shipment. This will include instruction to email our form back to them to confirm there has been no temperature excursions or damage to the study medication that you've received. The label for the trial IMP says store below 25 degrees C. The temperature monitoring of IMP storage at site should be carried out using existing local systems, with any temperature excursions greater than 25 degrees reported to the Bristol Trial Centre immediately. In the event of a temperature breach, the study drug should be placed in quarantine while awaiting further instruction from ourselves. Okay, so there are separate prescription forms for the active run-in and post-randomization time periods. A prescription form, one for each time point, needs to be completed and signed off by a medically qualified member of the team with delegated responsibility. The prescription form will contain the participant's name, trial identification number, culture scene, trial IMP box numbers, and a visit time point. I think we've already agreed the use of your own prescription templates. Is that right, Lucy? The labels on the study medication boxes are in booklet format. The pharmacist is to complete the participant ID, name, initials, date dispensed on page 1 of the labels. Please review the Roam manual and slides for instructions on how to use the Roam system. The system will let us, the UK trial management team, and you know when stock levels are low. When acknowledging shipments on Roam, if there have been any temperature excursions or damage to the boxes, please specify this. These boxes will be placed in quarantine and won't be available for dispensing on the system. The international sponsor will review and take boxes out of quarantine if appropriate. In terms of accountability, this is all captured on Roam with the exception of actual dispensing time. This is because a box is marked as dispensed on the system at the time point it is allocated to the participant. Therefore, there is a requirement for pharmacy staff to complete paper dispensing log to capture actual dispensing time. And use of your own dispensing logs has already been approved by us. So this slide shows a screenshot of the Roam system with different sections for participants, shipments, and inventory. The tabs to access run-in, rerun, randomization, resupply forms have recently changed. So please refer to the training slides on the study website and the manual on how to access these. Research team pharmacists to add return number of tablets on the Roam system. This will let the UK team know when ready to destroy or any returned study medication. We will check accountability on Roam and give you a go ahead for any destruction. It is unlikely that unblinding will need to happen, but there is a 24-hour unblinding service available, and the contact details for this are on the patient card. Email notifications will be sent to the local research team to notify them that an unblinding request has occurred for a particular patient. So I'd just like to move on to safety reporting now. So as you're all aware, safety reporting is a fundamental principle of GCP. This means capturing not just information which is of use or interest to the study, but also that it's required to demonstrate compliance with GCP and the clinical trial regulations. The principal investigator in LeaderPad must have oversight of the safety of the patients who are taking part in the study. In LeaderPad, you may hear about safety events from participants at follow-up visits, from being notified of emergency unblinding requests from GPs, or via admissions to hospital. Although the safety reporting for LeaderPad is quite limited, it is still important sites maintain full clinical records of untoward medical occurrences. This includes assessments by delegated investigators of whether they meet the thresholds for recording and reporting according to trial processes. In the first instance, the event must be recorded in the medical notes and signed off by a delegated medically qualified member of the team. Secondly, adverse reactions that result in permanent drug discontinuation. The flowchart detailed on slide 58, which we'll come to, should be used on how to report the event. Because the safety of colchicine is well known, we are using a risk-adapted approach to adverse event collection and reporting. This is limited to related adverse reactions that require permanent drug discontinuation, with the following exceptions. Study outcome events are recorded on CRS but are not reported as safety events, and events that are expected to occur in high frequency in the population are not recorded or reported as safety events. This is all detailed in the protocol in the UK, protocol in section 10, safety monitoring and reporting. I won't run through all of this, but this slide details the list of exempted events. This can also be found in the protocol in section 10.2 and also in the instruction page of the SAE CRF work package. The reference safety information for the trial is in the SMPC. Here you will find a list of expected events associated with colchicine. I just want to highlight that the causality terminology used in the safety report forms are slightly different from the standard UK terms. So non-related is no on LeaderPad, and definitely related is certainly related in LeaderPad. As mentioned earlier, this is slide 58, where the flowchart details the reporting for safety events. As you can see, if there is an adverse event which resulted in permanent discontinuation of the study medication due to a reasonable potential causal relationship, you first of all need to establish if it is serious. If it is not serious, you complete the permanent discontinuation CRF on the database. If the event was serious, you are asked to consult section 10.2 of the protocol to determine whether the event is exempt from expedited reporting. If yes, then you could just complete the permanent discontinuation CRF on the database. If the answer is no, an SAE report will need to be completed within 24 hours on the database, along with a permanent discontinuation form and an informative email to the BTC. If the event is ongoing, then the site must complete the follow-up report form within 5 days of completing the initial report. Further, follow-up report forms do not need to be completed within a specified timeframe unless the UK sponsor informs you that this is a requirement. They should only be submitted if there has been a significant change or update of the safety event. Other nations do not need to follow up SAEs in the same way that we do in the UK. The SAE follow-up form is unique to the UK and needs to be completed on paper and a copy emailed and scanned and returned by email to LeaderPad trial mailbox. This should be completed for all unresolved events. So just work through the case report forms now. So here we outline the main data collection forms for screening, baseline, randomization and follow-up visits. Just to note, where data is completed on paper first, there is an expectation that it is added onto the database within 24 hours. Please note that where there are lab results recorded at randomization, EGFR for initial eligibility and FBC results, evidence of these needs to be uploaded. All evidence must have identifiable information redacted and just include the study ID. Just to point out, if patient repeats the active run-in period, you will need to complete CRS 020 to 022, which are in fact a duplication of CRF 001 to 003, but under a rerun heading instead of just run-in. You will notice that run-in and randomization forms need to be signed off by a medically qualified study doctor. This slide shows the outcome forms. You must upload evidence for these events. Evidence that can be provided is detailed in the data collection manual. All evidence must have identifiable information redacted and just include the study ID. So I'd like to point out that in the future, an amendment is going to be made to include heart failure as a study outcome. Until then, you can complete the question about whether the participant has heart failure on the randomization and follow-up forms, but the heart failure outcome form is disabled on the database. No further information should be included about the event. Here you will see additional forms that are completed as and when are necessary. Follow-up SAE forms are only completed in the UK. They are completed on paper and not entered onto the study database. The major protocol deviation form is a bit different from what you may be used to. Sites have to complete description of the event and the date it occurred. Then the international sponsor will classify it and provide additional instructions to the site. In the UK, we will be responsible of any onward reporting to MRHA or REC as required. There is a slide on site protocol deviations on the trial website, which we ask you to read through. So we can provide one staff member access to the test site now to check if the IT blocks have been there are for your port, and I suspect that's already been done by yourselves.
Yeah, that's already done, Craig.
Yeah, thank you.
Yeah.
Oh, so for audit checks for data queries, so this emails will be sent to the PI and a main coordinator or research nurse. So please let us know who you would like us to put as the main coordinator research nurse for data queries. So that's it from me. I'm going to hand over to Surinder. Are you going to run through the slides yourself, or would you like me to share, Surinder? So you're on mute.
So yeah, if you don't mind sharing it, I'll probably
of course.
Just go through the notes. Okay, so we are at the website section. Oh, sorry, 12. Yeah. So we move on to the study website where you can locate the study documents and training materials. Next slide, please. Have the next slide.
Yeah, sorry.
Yeah, so you'll be sent a link to a recording of this SIV, and training will also be provided via the manuals and videos These are stored on the restricted site access. Sorry, the restricted site access part of the trial website. You'll need the matrix. The matrix on the next slide shows which documents you need to read and watch. So this just goes through which training you'll need according to your role. So you just check your study role and just complete the training and provide the CVs and GCPs that are needed for that. You'll need to confirm that you've completed the requested training on your online delegation log entry on a system called Mango. So yeah, here's the copy of the website and just showing which links you need to go into where the study information is stored. Can I have the next slide, please? So the 13 is the trial management system, which is called Mango. It's an online delegation log. You might be used to doing paper logs, but this is a more high-tech version. So a key task for your site is to maintain and store your study delegation logs. It's an important principle of GCP, that's good clinical practice, that any staff conducting study activities are appropriately trained and qualified to do so. The delegation logs are a way of demonstrating this training, which is why they're so important. Any changes to the delegation log, including new members of staff or staff leaving, need to be authorized by the PI, the principal investigator. So we're using this in-house electronic delegation log called Mango. So please make sure you have completed all your training for your role as highlighted on the training matrix, and then register with Mango. And Mango asks for code words to show that you've watched the database and Rome training videos if they're relevant for your role. And just to note that at least the main pharmacist and the technician, that's 2 lead members of the team, should be added to the study delegation log. We're happy for other members to be on your pharmacy delegation log, as long as you can send us a copy of the log. And just to emphasize that we need a signed and dated CV, and that the CV and GCP both need to be current. So that's dated within 2 years for the CV and within 3 years for the GCP certificate. Are there any questions on that section?
You've already liaised with our pharmacists, isn't it? Our pharmacy side.
So we're meeting with your pharmacy team. We've been in email communication with them already to kind of talk about the prescriptions and that. But we've got a separate session with them at 2 o'clock this afternoon where we'll go through everything with them. Yeah, and then we'll be back in touch. So we'll hopefully finalise their prescriptions that they want to use and their accountability logs, and obviously they'll be passed on to you. So yeah, we'll talk to them about registering on Mango as well at that point as well.
Great, thank you.
Brilliant, thank you. Craig, would you mind just sharing that last slide just with the final thing about setup? That'd be great, thank you. Brilliant.
Second, sorry.
Yeah, just move on one, yeah.
Yeah.
So just to mention before we get on to the last slide, so the LeaderPad trial, we are on the associate PI scheme, and we are finding a lot of sites that were, particularly the top recruiting sites, do have an associate PI working on the trial there. So I don't know if you've heard of the scheme before, but basically it's an in-house kind of training opportunity for someone who wants to develop their career in research to work alongside the PI to gain that kind of experience. So they'd, in order to join the scheme, they'd need to sign up onto the kind of delegation log for the trial, complete all the training, and then submit an application to be part of that scheme, which the obviously PI at site has to agree to. Complete tasks on the trial for about 6 months, and then complete a checklist at the end to demonstrate how they've helped support the study with all various different tasks, but largely screening and recruitment into the trial. So yeah, our top recruiting sites do have associate PI supporting the PI to help with that. So if you need any information about that, yeah, just come to the mailbox and I can send further details through of that. Next slide, please, Craig. So this is just kind of a final slide about setup processes. So there's kind of a two-stage green light process in LeaderPad. So once everything is completed within that first box, so we've obviously already had the signed contract. You've already localized all the documents, and we've got CNC for your team. So it's a matter of getting everyone onto the delegation log, completing all the training. At that point, when everyone's been signed off by the PI on the delegation log, we initially grant access to the online IMP management system to pharmacy staff. We send a pack of all your study documents to our sponsor rep within the university to review. They then give us green light to ship the IMP out to the pharmacy team. Once the pharmacy team have confirmed that shipment and have completed the necessary delivery paperwork that comes with that shipment and returned that to us, we then grant everyone else within the team access to the online IMP management system and to the database. We confirm with you you're able to access OK. And then we go ahead and activate your site, and we send an official green light letter to start recruiting. So yeah, this is kind of a two-stage process. So green light for shipment and then green light to start recruiting. Next slide, Craig. So obviously all the costs are detailed in the contract, but just to remind you that we email sites quarterly, so they come from Surinder, about dropout patients that failed the active running period that can be claimed for, along with requests for travel and postage you'd like to claim for that quarter. So randomised fees are paid for at the end of the trial, but quarterly you can invoice for the dropout patients and travel and postage. Just a note on travel, we have been talking to our funder about the amount of money that's in the budget for travel, as we're finding some sites had quite a big kind of catchment area to the hospital, and we didn't want to exclude participants that had kind of higher travel expenses. So at the moment, we're doing it on a case-by-case basis. So if you do have participants that are going to incur more than the £22, please do let us know, and we'll probably will say yes, do go ahead and approach them. We're just keeping an eye on that budget at the moment with view to requesting a bit more money to supplement that area of the grant. Yeah, and next slide, Craig. Yeah, and I think that sums it up. So obviously we're contactable via the mailbox, and we've also got a shared phone number on our signature. There's also individual email addresses and phone numbers that you can use if you can't get through that way. What we aim to do is send out a report probably by Wednesday, which will summarise everything from this session and pharmacy session with kind of remaining actions. But in the meantime, you can go on to Mango and start creating accounts on that system. So the Mango manual is on the study website with all the other documents as well. But yeah, I don't know if there was any other questions.
Great, thank you.
I did get access to the Mango management already.
Yeah.
I just was trying to add the study obviously to my account, and they did
so
ask
you're already
for
on Mango for something else already, and then you're
no,
no, you're not.
I
You
had
just
yeah, I just wanted to add this trial to it.
Yeah.
What start date do you think I should
with the start date you can even put today, because it's obviously the day you start the training, so that's fine. It doesn't mean that you can't start work until we obviously activate you as a site, and or if it was you already activated and it was new member, it'd be one the PI signed off, so that's fine. Yeah.
Okay, cool, thank you.
And with the training videos, they're all on the study websites. The links to those in the training section. So the code words that Surinder mentioned, they come from the Roam and database videos. Obviously, if you're not going to be doing any tasks that involve using the database or the online IMP management system, then you don't need to complete that training, and we can see by the tasks you selected. So we won't obviously reject your entry if you haven't selected those tasks. For the Roam, the task that's relevant for your team, if you're going to be needing access, is task 17, which is going on there to get the kit numbers on to write on the prescription. So if you're planning on using the system to get kit numbers to dispense to participant, you need to select that task, and you do need to complete the Roam training in that case.
Oh, could I ask a question?
Yeah, of course you can.
Lucy? Sorry. So I know you this is an electronic file as well, you can set up. So then does it mean that all we have to keep is the consent forms and we can throw the rest away?
What do you mean throw the rest away? So you're going to have an
Yeah, so if we upload like all the information, from the questionnaires and from the CRS, then I don't have to keep that. I can throw it away.
If you're doing them on paper first, obviously there's an option to direct data entry, then obviously it's all in the system. But if they're the original source documents, you would need to keep them if you do them on paper first. As with this, so you probably want a separate file just to store the consent forms, like you said, any prescriptions, if you've done anything on paper first, questionnaires, but it'd be a simplified folder. It wouldn't have all the, so you can have all the,
Okay, all right, thanks.
Thank you. Lucy, will you share the slides from today as well?
Yeah, so we'll send, when we wrap the report, we'll send the slides and the recording as well as the report as well. And then we'll have like a little summary of just the kind of actions that need to be done to move forward.
Great, brilliant. Thank you. So forgot to say earlier, so Yvonne is our study nurse. So data queries to email to me and Yvonne. And then
so in the main, so set up the system at the moment where it will automatically send them to yourself as the PI and to Yvonne, who's the main nurse, but we can add more people. We found in other sites that we've had those main two, and then you've got other nurses that have been involved or doctors been involved, and we can add people to that distribution list as well.
Thank you. And Vanessa and Calvin are on we're hoping to join the associate PI scheme. So
brilliant.
Given the go-ahead for 2 to support, and it looks as though Calvin's already ahead of the game. He's already logged into,
Brilliant.
I already
you registered it, and then with that they do, so you might need to, I guess it depends what start date you put on the associate PI scheme, but they like you to have 6 months where the trial is like open, I think, so that you've done recruitment. So you might need to, if you open slightly later than you put for the start date on that, I know with some other one, I think it's quite easy to go back to them and just say that you want to amend that start date. But and then we get a notification for
the end of April, I think.
Okay, so that's fine. So it should be fine then. Perfect. Brilliant. Any other questions or?
Not at the moment for me. Yvonne, are you happy?
Yeah, that's fine. It's straightforward.
But when we do open you, when you've got your first patient in, if you just let us know, if you've got someone coming, we can help with all the systems like getting onto Rome for the first patient and stuff like that. So we do that with lots of sites. And then once you've done it once, the systems are fairly, straightforward to use.
Great. Lovely. Thank you very much.
Thank you. Take care, everyone. Have a nice day.
See you, everyone.
Thank you.
Thank you.
Thanks, everyone.
Bye.
Bye.
Bye.